Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
All right, welcome bitches to the Transformation Nurse Academy podcast. My name is Kevin. Sorry I wasn't here last week, but I had shit to do. But this week we're going to continue on with our assessment of our head to toe. This week is our GI tract system. Again, I created a ebook that you can download at our website at transformationnurseacademy.com. Again, it's free. You ain't got to pay for shit. You just got to go over there, click on it, put it in a cart, and check out. I don't have a price on it, so take advantage of it while you can, because it may not be free for long. But again, welcome to Transformation Nurse Academy podcast. My name is Kevin. We're going to delve into some topics that will empower you to provide excellent care for your patient, because anybody who knows me, I love nursing. I'm very passionate about teaching. I do want to give a shout out, though. You know, my wife owns Central Valley Medical, and we teach a lot of classes at Central Valley Medical Education Incorporated. Our website is www.morethancpr.com. We're offering now Heart Code Complete courses where you can take classes online through the American Hearts class. And then we have machines that will be stationed throughout Madera, Merced, Bakersfield, Visalia. We're going to have one in Vegas soon. Hopefully, if I can get fucking Matt Norman to get his ass up and running, we can get a machine in Florida. But I really would appreciate your support. You know, we're a small business, and so, you know, I don't only work on the floor 4 days a month, and this is how we pay for our kids. And, you know, we have 6 other employees that we pay for. So we would appreciate your help. If you're a hospital administrator or CEO, please don't hesitate to ask us about using the RQI Heart Code system. Not only does it improve patient skills, it can save you hundreds of thousands to millions of dollars using the system. So let our company show you how to do that for you. All right. So I appreciate you letting me put in a little plug. Again, my name is Kevin. I'm your host. We're going to be exploring the intricacies of the gastrointestinal assessment. It's an essential skill for nurses in all settings, from primary care to emergency departments. So to kick off things, we're going to talk about a quick overview of the GI tract. So this is a complex system that's responsible for digesting food, absorbing nutrients, and eliminating waste. But it is coming to find out that gut biome is a big thing, and that it's part of our immune system as well. So that's something that I think that we should start paying attention to, because I don't know if nurses understand that. Or doctors maybe even. So this complex system, it stretches from your mouth to your ass or your anus. And it includes key organs such as the stomach, the small and large intestines, your liver, your gallbladder, your pancreas. And it's necessary to understand the system structure and its functions, because this is a fundamental aspect to understanding your assessments and what interventions may or may not be needed for your patient. So that's the topics of our discussion here, and that's also what's in our ebook as well. So just a little highlight key point: the GI system not only facilitates digestion, but it also acts as a critical barrier against pathogens and plays a vital role in our immune function. Disorders in the system can lead to significant impacts on the patient's overall health and quality of life. All right. So let's delve into the anatomy and physiology. The anatomy and physiology, like I said, it starts in your mouth. That's where digestion begins. Enzymes in the saliva start breaking down our complex carbohydrates. The esophagus is a muscular tube that transports the food from your mouth to your tummy using what we call peristaltic movements. Peristalsis is just waves. The muscles contracts in waves, and it kind of brings things down. So the stomach further breaks the food down using gastric juices, turning it into a semi-liquid mixture called chyme. Now, I don't know if you ever heard of chyme, but chyme is sometimes what people hear when you're a farmer I don't know if I'm saying it right, but that's how I'm saying it. Chyme. So chyme actually is pronounced Kim. Listen to this. Chyme. So it's pronounced chyme. Chyme is the pulpy, acidic fluid which passes from the stomach to the small intestine, consisting of gastric juices and partly digested food. Does that make sense? So that's what your chyme is. So the small intestine is the main site for the nutrient absorption and consists of three parts: the duodenum, the jejunum, and the ileum. The duodenum receives bile from the gallbladder and the pancreatic enzymes, which are crucial for digestion. So if you're a diabetic, or maybe you're obese and you have a problem, or maybe you got pancreatic cancer of some sort, your pancreatic enzymes aren't producing as well, or maybe not as all, and that can affect your digestion. So you have to think about that. The jejunum and the ileum are responsible for absorbing the nutrients in the water. Any dysfunction in the small intestine can lead to malnutrition and dehydration. So sometimes, if a patient can't eat by their mouth, if they can't swallow food down their esophagus, they may have what's called a gastrointestinal tube or G tube. If it's not your stomach that's causing the issue, could be your duodenum or your jejunum, and they have what's called a duodenal tube or jejunum tube. And so you may feed in these tubes where the tube actually goes. It's called a J tube, and it actually goes into your jejunum, and it bypasses your stomach, and food gets put right there in your jejunum. So again, like I said, the jejunum and ileum are responsible for absorbing water and nutrients. Any dysfunction in this can lead to malnutrition and dehydration, which can be life-threatening if not addressed properly. So if you do have patients that come into the hospital or to the ER and they have G tubes or J tubes, you want to make sure that you understand these and make sure you get your competencies on how to access them, how to assess them. Don't just say it's a G tube if you don't know where the tube is going. Make sure you understand where the tube is ending so you make sure you document correctly. Because if it is a gastrointestinal tube in the stomach and you document a J tube, or if it is a J tube and you document that it's a G tube, that means you haven't properly assessed your patient and it could come back on you and your license. The large intestine absorbs water and electrolytes, transforming the liquid chyme into a more solid form before excretion. It includes the cecum, the colon, the rectum, and the anus. So disorders in the large intestine can cause constipation, diarrhea, and complications. So in our large intestines, which is here in your middle of the section, right around your around your belly button at the top, you have your ascending colon, you have your transverse colon, you have your descending colon, your sigmoid colon, and then you have your anus and rectum and ass down there. So it depends on if somebody has a colostomy, where they have it in their large intestines. If they have it on the ascending colon, you most likely they'll have more diarrhea and loose stool. As you go along the transverse, more water gets absorbed. So your feces that comes out of your, if you don't know what feces is, that's fucking medical term for shit. But if you have a colostomy across a transverse, the further you come across closer to the descending, it's still kind of liquid and soft, but less liquidy and more soft and formed. The lower it goes down, it's more formed because more water has been absorbed. So, it just depends on where your colostomy is at and why they have it and how your intestines look, on the inside. Accessory organs like the liver produce bile. And if you don't know what bile is, it comes from your gallbladder and your liver. And bile is a greenish color solution that bile is a bitter, greenish brown alkaline fluid that aids in digestion as it's secreted by the liver and stored in the gallbladder. Does that make sense? So that's when people come in, they complain of gallbladder pain. It's usually that they have bile that produces bile stones or gallstones. Or gall is a yellow greenish fluid produced by the liver, mostly vertebrates, that aids in digestion of lipids or fats in the small intestine. In humans, bile is primarily composed of water, produced continuously by the liver and stored and concentrated in the gallbladder. So that's why if it gets too concentrated, you get gallstones and it clogs up the tract, and you get stomach pain, and you may have to have your gallbladder removed. But what the problem is, sometimes the physicians don't tell patients is even though you get your gallbladder removed, you can still get that bile sludge blocking up the common bile duct, and you still have those same pains like you had your gallbladder. But now what do? You have to do what's called the ERCP. You have to go in through the intestinal tract up into the common bile duct and pull out that sludge. Anyway, accessory organs like the liver produce bile, the gallbladder stores it, and the pancreas secretes a digestive enzyme and hormones that regulate blood sugar. So, in a trauma setting, though, because I'm an ER nurse, and sometimes we see traumatic patients, and you may see them in a non trauma hospital. It doesn't make a difference. If you're in the ER, you may see this shit. But in a trauma setting or a non trauma setting, injuries to the small and large bowel can be critical. These injuries may not be immediately apparent because, somebody's got a lot of adipose tissue and they got a perforated bowel or a perforated small bowel, large bowel. It may have been tamponaded off and the leak is slow. And so if a small bowel perforation or rupture goes unnoticed for as little as 60 to 90 minutes, the patient has a higher risk of mortality. It can cause peritonitis and sepsis because if you have a hole in your small and large bowels, basically just leaking shit. And if you leak shit into your abdominal cavity, we call that peritonitis when it gets infected and the patient becomes septic. So remember that small intestine is where most of the absorption happens, and any dysfunction can lead to impact nutrition, overall health, and it could even cause your patient to become septic if it's leaking into the abdominal cavity. Remember sorry, your abdominal cavity is very vascular. So once that peritonitis infection gets into this vascular system, it goes everywhere. An interesting aspect of the GI system is connection to the immune system. The gut houses trillions of microbes that help modulate the immune system response and protects against infections. If you don't know what about gut biome, you should start paying attention because it's going to revolutionize the way we take care of our patients, the way we take care of ourselves. When they talk about gut biome, they're often referred to as gut biome, which plays a crucial role in maintaining health and preventing disease. A healthy gut biome, that's why they want you to drink kombucha or eat some fucking kimchi. I love kimchi. Maybe some apple cider vinegar, probiotics. Those things are what helps maintain your gut biome, a healthy gut biome. When you get some kind of bacteria that your body doesn't like, it fights with your bacteria in your gut, and your body tries to fucking shit it out. That's why you get diarrhea. But if you start paying attention to your gut biome, you may have a better outcome for you and your patient. So this is often referred to as gut biome, which plays a crucial role. A healthy gut microbiota contributes to the development of the immune system and helps in the production of short chain fatty acids, which have an anti-inflammatory property. Conversely, an imbalance or a I don't even know how I'm saying this right. Dybiosis. I gotta look how to pronounce that shit. I should have done that before the show, huh? Let me see. Diabiosis. So diabiosis is an imbalance in the gut biome or community of microorganisms that live in the body to help its function. It can be characterized by a lack of diversity, increased numbers of bad bacteria, decreased numbers of good bacteria. The term dysbiosis or dysbiosis can also involve changes in the functional composition and metabolic activities of the microbiota or a shift in their local distribution. Does that make sense? So, see how to fucking pronounce. I like this. Pronounce diabiosis. Man, they don't. Oh, it's because I put in the fucking word fucking. See, this is one thing I don't like about AI. Google's AI is limiting my way to say fucking. It's called dubiosis. Let's hear this shit. Dubiosis. Nope. They don't understand me. See, they don't understand the fucking Dysbiosis. Dysbiosis. So just remember that. So a healthy gut biome. So conversely, I can't fucking talk today. Conversely, an imbalance or a dysbiosis can lead to increased susceptibility to infections and inflammatory conditions. So a diverse and balanced gut biome is linked to better immune function. It can reduce inflammation. So promoting gut health through a diet and lifestyle can support overall immune resilience. All right, so let's talk about some symptoms and conditions that you may encounter. So, if people have gastrointestinal issues, they can have nausea, vomiting. Nausea, vomiting can be associated with gastroenteritis, can be with pregnancy, medications. There's many reasons. But the problem is when people are nausea and vomiting, we want to throw medicines at it. But you also got to think about what is causing the underlying issue, because if we don't fix that, it's just going to come back. Antiemetics are just keeping people comfortable and it's masking the symptoms, but we're not fixing what is the actual cause underneath. Other things that can happen is diarrhea and constipation. It can result from dietary factors. If you go from one extreme to the other, if people start fasting, they get dehydrated, so they don't maybe not really poop a lot. And then when they start eating again, your bowel gets all crazy. Then you start fucking shitting your pants. Yeah, so it just food. Food can affect it. Infections, different infections, chronic conditions like irritable bowel syndrome can cause diarrhea and constipation. Abdominal pain and bloating may be indicated. Any kind of ranges from digestive upset to serious conditions like appendicitis or bowel obstructions. These are things that could cause your abdominal pain and bloating. GERD, which is gastroesophageal reflux disease, characterized by acid reflux. It can lead to complications like esophagitis. So usually maybe like your sphincter, your pyloric sphincter, one of your esophageal sphincters causes you to reflux acid from your stomach into your esophagus, and it can be irritated. Um, could be stress, could be bronchospasms that could also irritate that as well. Peptic ulcer disease. Peptic ulcer disease can be caused by H. pylori infection. In the old days, we thought that ulcers were only caused by stress and drinking and stuff, but it can be caused by something called H. pylori infection. Could be NSAID use, but it can lead to sores in the stomach lining and cause a lot of pain and stuff. Like I said earlier, irritable bowel syndrome, a functional disorder with symptoms like cramping, abdominal pain, bloating, gas, diarrhea, and constipation. It is different than IBD or inflammatory bowel disease, which includes Crohn's, ulcerative colitis, causing chronic inflammation of the GI tract. And a lot of patients have severe diarrhea and stomach pain with this. So these are just some of the symptoms and conditions that you may encounter in the ED. So your understanding of these conditions will help you recognize the patterns and try to come up with an effective plan on how to intervene to have better outcomes for your patient. All right. So how do we conduct an assessment for the GI tract? It's a vital part of your head to toe assessment. So you want to start with a comprehensive history, interview the patient, gather subjective data, ask about their dietary habits, ask about their medications and their symptoms and their history of how long this has been going on. So when it comes to the physical exam, you want to inspect. You want to observe the abdomen for dystensia, any scars, any bloating, any lesions. And then I know I don't have it in front of me, but then magically you have to have this thing that you put in your ears, which comes down to a little round bell. It's called a fucking stethoscope. You have to auscultate all four quadrants. Are the bowel sounds hypoactive? Are they hypoactive? Are they not fucking there? You got to auscultate because you want to know what's going on. And then you want to percuss. Percussion helps determine whether there's a presence of gas or fluid in the abdomen. You want to palpate. You want to assess for tenderness, assess for masses. In pediatric patients, if you palpate an olive-like shaped mass, that's a sign of a pyloric stenosis. If you palpate a sausage-like mass, that could be a sign of a interception. In adults, you want to palpate all four quadrants. You don't want to just try to mix it. You want to put your quadrant in your abdomen in the four quadrants. Upper right pain could be a liver, Lower right could be your appendix. Lower left could be your bowels and your stomach. Upper left could be your pancreas. There's different things that you want to assess for and palpate so you can get a clear picture when you're doing your physical assessment. Each step in your physical exam can provide you valuable clues about the underlying issue. Again, listening for bowel sounds and assessing for tenderness or distension. Those things can help you, get a clear picture of what might be going on. There may be diagnostic tests the physician orders. He or she may want to order blood tests like liver function tests like lipase, amylase. They may want to do a rectal exam and check for the fecal occult, blood in your stool. They may want to do, I think it's called the O&P, ova and parasite, or checking for, bacteria and parasites that can cause you to have fucking diarrhea or constipation. You're looking for maybe x-rays, maybe a KUB, CT scan of the abdomen with or without contrast. The FAST exam, FAST, F-A-S-T, stands for Focused Assessment Sonography for Trauma. It's a bedside ultrasound, can help you see if there's fluid or blood in the abdominal cavity. We don't really do a DPL that much anymore, diagnostic peritoneal lavage. So if you work out in some facility that still does DPLs, I sure like to know about that shit. I don't even know if we should be doing it, but I know it can be done. Maybe the patient needs an endoscopy procedure, EGD or colonoscopy, so they can have a direct visualization of the GI tract and maybe do a biopsy if they see polyps, or maybe cauterize your peptic, your bleeding ulcers in your esophagus and shit like that. As a nurse, though, you want to make sure you advocate for the most appropriate diagnostic tests, and it's helpful and it's crucial when you're trying to diagnose and create a treatment and plan for your patient. And then once you do all of this, you want to make sure you gather all your assessment data. You want to interpret the findings. You want to help develop an effective care plan. You want to recognize normal versus abnormal. Is a patient bleeding? Are they having acute abdominal pain? Are they having acute abdominal bleed? Is this old? What color is the blood? Is it bright red? Is it dark, tarry stool? What's it smell like? These are things that you want to pay attention to when you're doing your head to toe assessment. Some nursing interventions after you gather all your equipment could be dietary modifications. It could be medication management. If you got a patient on a GI bleed, you may want to have the physician think about starting an octiotride drip. If you don't know what an octiotride drip is, the other name is called sandostatin. If they don't want sandostatin, you could use Protonix maybe to help with that, a Protonix drip. So you got to think about the different kinds of medications you might need, that will help the patient until they get home and have a long-term care management plan. So in the emergency setting, prompt recognition of these conditions and stuff can be life or death, especially when it comes to bowel injuries, because many missed bowel injuries can lead to rapid deterioration and death due to sepsis. You always want to maintain a high index of suspicion for bowel injury, especially in trauma patients, because timely intervention can be life-saving, and you want to always collaborate with your healthcare team. We are a team. We're not just fucking robots and shit. All right, so here's a scenario for you. You got a 45-year-old man. He arrives in the emergency department after a high-speed motor vehicle collision. He complains of severe abdominal pain, nausea, and vomiting. Upon assessment, his abdomen is distended and tender with hypoactive bowels. So what are we going to do? We're going to start an IV, probably a large bore, probably 2 large bore, because it is a trauma patient. If necessary, we may give some type of fluids, but you don't want to get too crazy because you don't want to cause the blood pressure to go up too high with the fluids, because you can pop a clot if they are bleeding, or you can dilute your clotting factors. So we got to be cautious in that. But you do want to give some fluids because they will need a CT scan. And if they do have a CT scan with contrast, you want to look at the BU and creatinine so we don't burn up the fucking kidneys. And then when you get your CT, what does it reveal? Well, in this case, it reveals a perforated bowel. So what is the nursing actions? What are we going to advocate for our patient? So again, we want to initiate IVs. We want to administer broad spectrum antibiotics to prevent infection. You want to prepare the surgeon, you want to prepare the patient because they're probably going to have surgery. So you need to make sure you have a consent. Make sure the physician consents the patient. Make sure you talk to the family and the patient. And then you want to do serial abdominal assessments. Check the abdominal girth. I don't know if they do anymore. If there's a way to do it, check the intra-abdominal pressure. Do a serial abdominal assessments or serial abdominal ultrasounds. Serial H&Hs to make sure that things are okay. Check the WBCs and hemoglobin to see if their patient is really bleeding. Again, like I said, a perforated bowel is a serious medical emergency that occurs when a hole or a tear in the wall of the gastrointestinal tract. This condition can lead to the leakage of intestinal contents into the abdominal cavity, causing peritonitis and sepsis, both of which can be life-threatening if not promptly treated. So the risk of a perforated bowel includes peritonitis. Peritonitis is inflammation of the peritoneum, the lining of the abdominal cavity, due to the bacterial infection from the intestinal contents leaking into the abdominal cavity. And then sepsis is a potentially life-threatening systemic response to the infection that can lead to organ failure. Abscesses can form. So abscess formation is a localized collection of pus or purulent material in the abdomen. Shock is a critical condition that results from a significant drop in blood pressure and blood flow to the organs. Shock is when your body is not getting enough oxygen and your body needs it. So when your tissues become hypoxic, they start to die, and as the cells start to die, they start to bloat. And then they break open and they cause a lot of fucking trash into your bloodstream. And I call it bacteria shit. And when that bacteria shits in your patient's bloodstream, your patient's blood vessels dilate. That's why septic shock is called distributive shock, because your fluids are getting redistributed to where they don't want to be. So, if left untreated, the condition can lead to death due to the severe infection and organ failure. The survival rate for a perforated bowel with peritonitis can significantly differ depending on several factors, including the patient's age, their overall health, the speed of the diagnosis and the treatment, and the underlying cause of the perforation. So you got to make sure you're paying attention to your patient. So timeliness of treatment. So the factors that influence survival rate with peritonitis and perforated bowel: timeliness of treatment. The sooner the condition is diagnosed and treated, the better chance of survival. Delay in treatment increases the risk of complications such, like I said, sepsis and multi-organ failure. Patient health, right? The younger the patients, those without significant comorbidities generally have better outcomes than older patients with chronic health. Cause of perforation, the underlying cause could be a traumatic injury, it could be a peptic ulcer, could be diverticulitis. There's different causes that may help keep it from progressing, or there may be the cause of it progressing even faster. The severity of the peritonitis, the extent of the peritonitis is depends on, how much it was leaked out, how soon it caught. But the overall mortality rate for peritonitis and small bowel obstruction, the mortality rates for perforated bowels and peritonitis ranges 10 to 30%. So that means there's a survival rate of 70 to 90%, depending on the factors that we talked about above. Complicated cases, in most cases where the patient develops severe sepsis or septic shock, the mortality rate increases to 40% or higher. And so you got to think about that. Elderly people and high-risk patients, people that have comorbidities and that are more sick, their mortality rates can be significantly higher, as 50% and higher. So you got to think about the age of the patient, their health factors. Those things can cause the different outcomes. So the prompt treatment, you may have surgical intervention. You want to have emergency surgery to repair the perforation. You got to wash out the abdominal cavity. The sooner the surgical intervention, the better chance of survival. Prompt administration of broad spectrum antibiotics is essential to control and prevent the spread of bacteria from the GI tract to the bloodstream. How long do you have to give fucking antibiotics? Well, I won't tell you where I work, but most of you know, and they're still teaching a 3 and a 6 hour bundle. But I thought that was bullshit, so I looked it up. So according to the new sepsis protocol that has been out since 2018. How long ago is that? 2018, 19, 20, 21, 22, 23, 24. That's 6 fucking years ago. And according to the Society of Critical Care Medicine and the Surviving Sepsis Campaign, the current is a 1-hour bundle. The current 1-hour bundle recommendations from the Surviving Sepsis Campaign were introduced in 2018. So if your hospital is still following the 3-hour and 6-hour bundle, that changed back in 2018. We don't have that long to treat patients. You need to give your antibiotics within the first hour so they can have a better outcome. All right. And I'll talk more about that in a minute. So, to thoroughly investigate and prevent missing of a perforated bowel, nurses should perform the following. Again, patient history, gather information, recent surgery, traumas, change in bowel habits, nausea, vomiting, things like that. Vital signs, frequent monitoring of vital signs, including temperature, heart rate, blood pressure, and respiratory rate. Again, you want to inspect, auscultate, palpate. Laboratory studies, imaging studies. So remember, we want to do that. All right. So when we're managing sepsis, you may need medications. So some medications that you may need if the patient does get sepsis are vasopressors. Some examples of vasopressors could be norepinephrine, epinephrine, or vasopressin. They're often the first line used to maintain adequate MAP and improve perfusion to the organs. You may need inotropes. Inotropes help with contractility, used to improve cardiac output in the patients with cardiac dysfunctions. Corticosteroids, steroids may help reduce inflammation and help improve blood flow and refractory shock in patients in sepsis. IV fluids. So look at that. First is vasopressor. Second is inotropes. Third is corticoid. What the fuck is last? Fluids. Because if you don't get the blood vessels to tighten up, you can give fluids all day long, but to keep third spacing, it's not going to work. So you want to make sure that you use the proper protocol. They may need blood. So if they got a perforated bowel, their hemoglobin's low. Typically now we don't treat unless the hemoglobin's below 7. You may get blood products, fresh frozen plasma. You want to monitor the glucose levels, control it with insulin, especially in critical care patients. You want to give analgesics, pain medications like fentanyl, morphine, but you also want to put them on sedation medications like propofol or dexmedetomidine that are used to sedate intubated patients and require mechanical ventilation. If they're really septic, they can develop bars, they can develop kidney issues, multi-organ failure. So they may need to have mechanical ventilation on a vent. For patients that have acute kidney injuries from electrolyte imbalances and fluid overload or severe acidosis, they may need to get some kind of renal therapy placement like dialysis. You want to think about the nutritional support. Do they need enteral nutrition or do they need parental nutrition? These are things you got to think about. You want to monitor in the sepsis protocol and the sepsis survival. You want to monitor the lactic acid. This is a crucial marker of tissue hypoperfusion and can help identify patients with severe sepsis. So you want to start the lactic acid. If the lactic acid is greater than 2, it should be remeasured to make sure you follow the appropriate treatment guidelines. Before you give antibiotics, you want to make sure you do blood cultures. We're going to do early appropriate administration of broad spectrum antibiotics. This should ideally occur within the first hour of recognizing sepsis. You want to give 30 milliliters per kilogram of crystalloid solutions. For patients with hypotension or lactic acids greater than 4, at least 30 milliliters per kilogram of isotonic crystalloid solutions. And then you want to apply vasopressors. If hypotension persists during or after fluid resuscitation, vasopressor should be used to maintain a MAP of 65 or greater. Norepinephrine is typically the first choice for vasopressors. So again, you're looking at the 1-hour bundle, you're looking at the lactic acid, you're looking at the broad spectrum, the fluid, and then your vasopressors. So just remember though, this was updated in 2018. The 3-hour bundle is a 2016 guideline, and the 6-hour bundle is also a 2016 guideline. So we want to make sure that managing severe sepsis, it requires a multifaceted approach that includes medications to support hemodynamics, infection control, and manage complications. The choice of medications and interventions is tailored to the individual patient's needs. Don't just fucking throw shit at your patient, because every patient has different things they need to do. Make sure you, like I said, make sure you do your diagnostic studies, CT scans, X-rays, CBCs, blood cultures, electrolytes, your CMP, BMP, your broad spectrum antibiotics, your blood cultures, pain management, and surgical outcomes. So as long as you follow these things and you early intervention, a great assessment, you'll have better positive outcomes. And if not, your outcomes can be pretty shitty. All right. So mastering your GI assessment is very important. It enhances your ability to provide a holistic and effective care to your patients. So remember the key points from today's discussion. And again, like I told you, that we have a comprehensive guide that we created, and we'll put it up on our website, transformationnurseacademy.com. We will have it up there, for you to download. Again, we're working head to toe. We did pediatric triage, we did adult triage, we did neuro, we did cardiovascular, I think respiratory, and now GI. All right. So I hope you guys learned something and shit. I appreciate you guys. All right. Fuck all you motherfuckers. Again, make sure you follow us. Transformation Nurse Academy Podcast, transformationnurseacademy.com. Don't forget about Central Valley Medical and their programs, their ACLS heart code, especially all you travel nurses. If you don't have time to spend time in class, you save money because if you make $60-70 an hour and you're spending 3, 4, 6, 8 hours a day for a couple of days to renew your ACLS and PALS and BLS and all that shit, you can do the heart code because you can do it online while you're at work. And then, like I said, we have these machines that you can go to all around the damn country. So that way you don't have to fucking spend all the time in a class. All right, you guys. I really appreciate you. Peace, bitches. Peace. Stay safe.
Don't miss out. Engage with us weekly. Share your thoughts. And let's transform the nursing landscape together.